everybody. I'm Dr. Deepak Jain, Senior Professor, Department of Medicine, PGIMS Rohtak. Today, I am going to talk on latest update in hypertension. In the last few years, we have seen some updates in hypertension. So, just to introduce, I start with the WHO has already shown that nearly 63% of total deaths in India are due to non-communicable disease, of which 27% are attributed to the cardiovascular death, which affects 45% people in 40 to 69 age group. Raised blood pressure is among the most important risk factor of cardiovascular deaths. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. If I talk about India, the prevalence has gone up to 30 years to 38% in a man and 32% in a woman, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of men and 41% of women with hypertension, were unaware of conditions. Additionally, about 62% of men and more than 53% of women living with the hypertension did not get treated. Medication was used to control blood pressure in fewer than 1 in 5 in a man and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempt to address the issue that in resource poor setting, optimal care refers to evidence-based standard of care, and whereas essential standards refers to minimum standards of care to allow specification of essential standard of care for the low resource setting. The American Heart Association or American Cardiology Society has released a scientific statement in 2021 offering new guidelines for the management of stage 1 hypertension among people with low atherosclerotic cardiovascular risk. Among low adults with no atherosclerotic cardiovascular death or 10-year cardiovascular death risk is less than 10% with the stage 1 hypertension. Blood pressure management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider start pharmacological therapy. There is another development we already know in this COVID area. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study, which appeared in a Journal of American College of Cardiology in 2020 September issue, which says that metoprolol can reduce the lung inflammation and improve respiratory function in people with a COVID-19 adults having ARDS. Another study, which published in 2021 in New England Journal of Medicine, which says lowering systolic blood pressure targets down to 110 to less than 130 milligram mm of Hg range substantially reduce cardiovascular adverse effects in a step randomization trial, affirming the sprint finding for an older Chinese population. They have taken around 8,500 patients aged 60 to 80 in China. The intensive target trimmed 26% of composite cardiovascular risk. Finding from this new second major trial sporting a lower target could initiate the guidelines, which even among US professional societies range from threshold of 130 to 150 mm of Hg. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommended that the diagnosis of a hypertension should not only be dependent on office BP monitoring, but also on out of office measurement, such as ambulatory blood pressure monitoring or home-based blood pressure monitoring. 24-hour and nighttime BP measurements were associated with a greater risk of mortality and composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 mm of systolic and 10 mm of diastolic increment of BP measured at night, the risk of mortality increased by 23% and risk of cardiovascular events by 36%. Another development which has taken place is when we see the most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommended five classes of hypertensive drugs, considering high non adherence treatment. The importance of combination therapy is particularly highlighted to improve the adherence of the therapy and blood pressure control. Therefore, the 2018 European guidelines recommended, especially in the context of lower BP target, to start antihypertensive treatment with initial dual fixed dose combination with ACE inhibitors or ARBs plus calcium channel blockers or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is detection of known carcinogen, namely N-nitrosa-dimethylamine, which can be found in a candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO, International Agency for Research on Cancer, to the carcinogenic in a human. If 1 lakh patients would have received the NDMA containing valsartan from China, which is a major producer, every day for 6 years in a highest doses, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they have taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits by around 6%. And last of all, if we talk about a HYGEA study, which represents the largest study that tested the nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy, in comparison to the usual upon awakening hypertensive therapy, exerts a favorable cardiovascular risk reduction. The largest study included a total number of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 7,052 participants experienced the primary cardiovascular outcomes. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleeps. The relative risk reduction for cardiovascular events was significantly improved for nighttime treatment when compared with the awake treatment. Thank you very much.